Hi, everyone. This is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. I want to welcome you to the Journal Club for the month of July. As always, obviously, I want to thank ESGO and IGCS for supporting this Journal Club. Just a few announcements. I want to mention a few housekeeping notes relevant to the Zoom platform for the Journal Club. Obviously, we're recording today's discussion, and the recording will be made publicly available. As you all know, participants with cameras turned on may appear in the video recording, and we ask that everyone please keep your microphones muted so that we can hear the presentations. Also, if you're having any difficulties or questions, message us on the chat, and our technical support team will hopefully be able to assist you. As always, we encourage questions from the audience, so please feel free to write in your questions via the chat, and I'll try to get through all of those questions. So with that, again, let's get on to the Journal Club. The lead article is titled Successful Bilateral Sentinel Lymph Node Mapping Rate and Empty Nodal Packet Rate in Uterine Cancer. We have the lead author, Sara Andres, and her mentor, Dr. Mario Lateo from Memorial Sloan Kettering Cancer Center and the Department of Surgery, Gynecology Service in New York City. So we're really always very excited to hear from the group. I'd love to see our colleagues from Memorial Sloan Kettering on the Journal Club as well. So again, Sara, Mario, thank you so much for allocating the time, and thanks to everybody who has joined for the Journal Club. So with that, we'll get started with the presentation, and then we'll get into the questions from our fellows as well. And again, inviting questions from everyone who has joined. So with that, welcome, Mario, Sara, floor is yours.
Thanks.
Thank you. We're thrilled to be here.
Yes.
So I just want to thank all of our collaborators here at Sloan Kettering. This certainly was a group effort, including all of those listed here, but also all of the surgeons and fellows who are here. Next slide. The objective of this study was to determine factors impacting successful bilateral sentinel lymph node mapping and the empty nodal packet rate using indocyanine green, or ICG, for uterine cancer staging. This was a retrospective single institution study from 2014 to 2022, including all patients with clinically early stage uterine cancer who underwent a hysterectomy with SLN mapping. Our primary endpoint was the rate of successful bilateral sentinel lymph node mapping, and we also looked at the empty nodal packet rate and factors impacting a successful SLN mapping. Next slide. We included 2,690 patients with a median BMI of 30.9. The majority of these cases were completed with minimally invasive, or MIS, surgery. Only 7% were completed with a laparotomy. Overall, our bilateral mapping success rate was 87%. In the cases completed by MIS, the success rate was 87.9%, and in the laparotomy cases, the success rate was 75%. Overall, our empty nodal packet rate was 3.7%, pretty low. On the right here in this graph, you can see our SLN mapping success rate over time in the top blue bar there. And you can see that the SLN success rate increases over time. Our empty nodal packet rate remained the same over time in that yellow line. And the purple represents our median BMI over time, so also unchanged. Next slide. In conclusion, high rates of SLN mapping can be achieved across BMI indexes and using ICG. So we saw that even at very high levels of BMI, patients with BMI up to 50, 55, 60, they had successful SLN mapping. However, once their BMI got above 60, they had a lower rate of successful SLN mapping. And we found that cases, over time, we had an improved SLN mapping rate with continued experience at this institution.
Thanks.
This is our visual abstract.
Excellent. Well, thank you very much, Sarah and Mario. Again, obviously opens up a lot of opportunities for questions and discussions. And as I mentioned previously, for those who are attending, to please send in your questions through the chat. We do have our fellows that always have prepared questions. And we're going to start with Eleonora Panisolo, who is now at the European Institute of Oncology in Milan. Eleonora?
Thank you, and my compliments to the authors for this interesting work. My question is related to pre-surgical planning. Although bilateral mapping remained feasible across BMI categories, the success rate decreased to 79% among patients with BMI of 60 kilograms per square meter or higher, although this subgroup was relatively small. From a practical perspective, how do you think these findings should influence preoperative counseling and intraoperative planning?
I can start, from a fellow's perspective. Whenever there's a patient with the extremely high BMI, 60 or greater, a surgeon can really anticipate quite a few intraoperative challenges. Is the patient going to tolerate positioning? Am I going to be able to, map the SLNs, and how successful am I going to be? So I think there are multiple challenges when considering surgery in a patient with that BMI, and SLN mapping is just one of those also difficult parts.
Mario?
I'm not sure that we really change much in sort of how we approach these patients, other than let them know that there's the bilateral mapping rate of 70% in the super obese group is still pretty darn good. It's probably better than some people have for just a general bilateral successful mapping rate. So it's pretty good. And we just use that as a point of reference when we're telling patients what the success rate is for finding those lymph nodes. Honestly, in a BMI over 60, if you're not mapping, that patient's probably going to have other medical reasons to be worried about in her life, and death from other causes. So honestly, if someone's BMI is over 60, I'm not going to do a full lymphadenectomy like our algorithm says, to be honest with you. That's just, you can't find the sentinel nodes because of the adipose in the area. Sometimes a narrow pelvis. So, you have them in Trendelenburg, anesthesia is giving you trouble about the pressures and all that stuff. So, that's probably why, is that we're a little quicker to give up. And someone who's got an endometrioid carcinoma, grade 1, who's BMI 62, and you can't find that sentinel node easily, I'm not looking for the lower pathways. I'm not looking for the para-aortic node. I'm not doing any of that stuff, to be honest with you. We have to use some individualized decision making, and patient safety and overall care is more important than being technically successful and to say you did something.
Yeah. Mario, as a follow-up to that, for that very obese patient, are you doing anything differently to hopefully increase the likelihood of identifying that sentinel lymph node? In other words, are you injecting more? Are you injecting, instead of 3 and 9 o'clock, do you inject 3, 9, 12, and 6? Or are you changing the concentration of the ICG?
No, we haven't done any of that, nor tried any of it. It's going to be hard to really do any kind of experiments or trials with not having that many patients over 60 on a regular basis. Yeah. We haven't done anything different. Again, with 70% being bilaterally mapped, that's still pretty darn good in my mind. And oftentimes the ones that aren't mapped, there's only not that many cases. We can even drill down to the ones who weren't mapped for more specific reasons. I'm sure it's and like what their histologies were. I can only assume that most of them were like a grade 1, or they were like a serous carcinoma. They're going to get chemo anyway, probably, right? So. So, or carcinosarcoma. So did we include those here? Yeah, we did. Yeah, that's right. I forget. Sorry. That's why I do it the fellows. They remember everything. So yeah, we could always just, maybe just as an aside, actually, that's interesting. We might just take a look at those cases that didn't map and see what their makeup is. It's not that many cases. We can just pull them out and see.
Yeah.
And then, Mary, before we get on to the next questions, take us through the sequence of how you guys do it at MSK. You're injecting, then docking, and proceeding, or do you dock first, or at least get in first, inject, turn the camera on, and see where it's not mapping and potentially inject more on that side? What is sort of like the sequence of how you do it?
So I can only speak mostly. I don't know what everyone. I mean, there's 15 of us, so I can't speak to everybody. Actually, Sarah probably better at saying what the overall practice here. For my practice, is I prep and drape, and then I inject before I get into the abdomen. That's been my practice for all these years. Dr. Aburustam, I know his practice. I know that he actually injects prior to prep and drape. I think, or unless he changed that.
He's the only one who
Yeah,
does
he's
that.
the only one who does that. But I think because most of the junior faculty trained here with us, so
Right.
so I believe that almost everybody injects after patients prepped and draped prior to entering the abdomen.
I would agree with that as the fellow. Yeah.
All
I
right.
would say one other technique that I've seen some attendings use with patients with very high BMI is when it's a robot case, ensuring that we have the table paired with the robot. We don't always do that, but then at least if they have a really high BMI, they have high peak pressures, you can take them out of T-Berg without undocking, and give a little break and then restart. That could be helpful.
Yeah, which is, if you guys don't know, there is with the XI system and D5, you can get a special table that actually pairs with the robot, so that you can actually move the bed and the arms adjust automatically. You never have to undock that patient. So our colorectal surgeons use that more frequently because when they're doing splenic flexure takedowns after LARs, APRs, so they can do multi-quadrant stuff. It is helpful, and it is a good trick. If you have that capability, obviously, not every place will have a robot, or then on top of that, tables that pair with the robot. Yeah, there's a special table you have to buy for that. And then our cases are mostly robot, but there's still a bunch that are laparoscopic too, so it's not just all robot.
Excellent. Very well. So thank you,
Although
Eleonora.
all the BMI over 60, though, those were all robot cases.
Yeah,
Because no one trying to straight stick laparoscopy in that case.
definitely.
I'm sure there's folks that do, but not here.
Yeah, and I would imagine you haven't done a laparoscopy in quite some time.
Yeah, I do laparoscopy. Yeah, when I get into the abdomen, it's all laparoscopy.
That's right. All right, very well. So thank you, Eleonora, and then we'll move on to Spain. Ana Conde.
Hello, congratulations to the authors. And as you all know, the memorial slow Catherine Sentinel lymph node map algorithm is widely recognized for its effectiveness. And my question was regarding the lower rate of detection in obesity and the challenge of empty nodal packets, if you have changed anything for this patient, but I think you perfectly addressed this point. So I'm also curious to know if you think that for the problem of empty nodal packets, if we change the visualization mode of the fluorescence with monochromatic, overlay, or intensity map, it can reduce this problem of the empty nodal packets. Thank you.
So I can say for the robot, we don't have that option. It's all just the monochromatic, it's just all the Firefly mode. It's been improved on the XI-DV5 where, and that's the only way I've always done it. So, so the majority of kids are robot. The only time that I do believe that Dr. Aburustam does the majority of the laparoscopic cases here, and he does like the overlay mode, intensity map or overlay, it's called, I guess. I don't know if we didn't look at laparoscopy versus robot detection rates, did we? Or if we did, we didn't put it in there. We didn't report it. Was there a difference? I'm not going to say. Yeah, all right, because it kind of says it speaks to only one surgeon, maybe. So let's just say it wasn't better than the robot, right? Can we just say that? It was all right. So so that's all. And again, we don't have in now super obese group any straight laparoscopy cases either to even make that commentary. So for the other groups, it wasn't better. I think it's just a style thing. Honestly, I got so used to the standard monochromatic, the dark view, that it's quite easy for me to do it that way. And all the robot surgeons here, that's how they do it. So the other one gives you nice pictures. You operate in white light. I don't know that it's better, to be honest with you, from what I've seen.
Excellent.
Thank you.
All right, excellent. So next we'll move on to Chiara Innocenzi from Policlinico Gemelli in Rome.
Thank you and congratulations again, and thanks for this insight. I was wondering, What are your thoughts on that histology, ethnicity, and the presence of lymphovascular space invasion did not impact the mapping success?
Yeah. I mean, these are supposed to be, clinically early stage cases. None of those should affect mapping. This is, looking at injecting the tumor or the cervix and seeing where those lymph channels go. So it makes sense to me that none of those affect SLN mapping.
Yeah, I think there's been some papers out there from smaller series suggesting those things, but I mean, I would ask the group, why would there be a biology or rationale why anatomic mapping would be impacted by histology or pathologic features like that? I mean, those are real risk factors for lymph node mets, and maybe you don't find the lymph node, a sentinel, because they have a higher rate of lymph node mets and they got nodes that are involved with cancer and embolize, and the dye doesn't get there. Maybe that's it, but at that point, you just take out that node that's enlarged, right? So that might be some of it, but for me, it doesn't make sense. You're mapping the lymphatics of the organ, and those lymphatics don't change based on these features. I mean, I've never heard of race-based differences in lymphatic drainage, but we haven't really looked at it. And again, histology, LVSI, I can't think of a reason why it would change the lymphatic mapping of the organ itself, other than if you don't map, it's maybe because of embolization of tumor lymphatics in cases that are higher risk for lymph node mets, if that makes sense.
Mario, as a follow-up to that, do we have, and I know obviously, as you mentioned, that we're mapping the organ, but do we have any data to suggest that the rate of sentinel lymph node detection is any different based on the actual tumor size of what is found in the uterus? And noting that, of course, obviously, we're not injecting the tumor.
Right. Yeah, I don't know specifically tumors. If there is, I don't know. If anybody on the here knows of that data, those data, please share it, I guess. But I don't know. I'm sure, because we don't really measure tumors either, routinely for our pathologists. There's not like a routine measurement of tumor. We measure depth of invasion, of course, and things like that, but I don't routinely see tumor size being reported. So I don't even know that it's not, right?
It's not reported on our pathology reports here.
Yeah, so we wouldn't even be able to look at that, and that's why we didn't look at that. Are you aware of anything that looks at tumor size?
No. And just when seeing the reports, you may see a tumor size that is like 1 centimeter versus a 9 centimeter endometrial tumor mass, and wondering if there was any data on the detection rate. And again, I mean, obviously, we're trying to detect the mapping of the organ, not of the actual tumor.
Right.
But yeah, I mean that was a question that I was thinking about as I was seeing different types of reports with different tumor sizes. So, all right. So with that, then questions from the audience are coming in, and congratulations for this educational article. I wonder if the authors could comment on the increased rate of bilateral mapping over the years. Is it just learning curve? In addition, the mapping rate significantly decreases for patients BMI greater than 60. This group has only 16 patients. The power is obviously not significant. And is it just the obesity for the cause of the low rate?
No, our BMI didn't really change, and then, like you said, it's only. I mean, it significantly changed, and but we went from 82% to 91%. So I mean, it's not like it doubled or anything like that. So there's definitely a learning curve to this. There's also depends on the percentage of cases done by certain of us who have a little more experience also. And then we have junior faculty in the mix also. So we didn't break it down that granular. We do have bilateral mapping rates by individual surgeons, but we're not sharing that, of course. So, but I can just tell you there's differences there also. So I think as a group, we all just got better, is what I'm trying to say. So the more you do, I mean, this is 3,000, almost 3,000 cases, it's just like anything else surgical, you just get better. You know where to look. You know if you don't, you know where to go first. You know how to open the spaces properly. That's something I see videos all the time, and folks just open that a little bit. They don't open the pararectal. They don't really see the channels. I mean, it's just learning how to do that well over time. Yeah, 16. You know, somebody mentioned power. You know, me and the word power in retrospective studies, you know, it doesn't really apply. You know, it's kind of trying to guess what the weather's going to be after it rained. But you know, or it didn't rain, you know, that power is really a concept of when you're designing a trial to ensure success rates based on your a priori baseline assumption. So yeah, all you can say is that it's a small group, so that the point estimate is more unstable, if you will. Meaning you're probably gonna have a larger 95% confidence interval because it's only 16 cases. So maybe next time when we update, it's worse, or maybe it's better. You know, that's all that means when you have an N of 16, and you can't overly conclude based on just 16 cases for sure. But that's all we have, and that isn't and that one, at least for the cause of this. No, and what's this has only is just and is it just the obesity for the cause of the slow rate? I think so, but like we mentioned earlier on, we didn't actually look at the ones who didn't map in the severely obese case what their other tumor factors were, and we can do that. That's actually interesting. We'll go back and take a look, and we can update you guys at some point. I mean, for my own, I mean, these are all robot cases. Are they all mine?
All of yours are robots, yes.
No, but are these BMI over 60 all mine?
I don't know that.
I
don't
anyway,
know. Yeah.
So I bet you, because doing it, I kind of, if it's not easy and there's a lot of adipose there, I just stop. Especially most of these patients have grade 1 endometrioid tumors. You know, you're like, what is the point? This patient's gonna, you know, this patient has a higher risk of dying from non-cancer related reasons than from her endometrial cancer. And then in that situation, we'll fall back to the treat based on uterine features approach, which, as you know, in some places around the world, that's kind of what some people are doing and saying. So, you know, it is a balance between, you know, benefit and risk to the patient during that procedure, right?
Yeah.
I don't know for sure. We'll look, but really, just from a personal experience, I can tell you, if it doesn't map easily in someone like that, I'm not pushing it. You know, you start to dissect, you don't see it. Then if you've all been there, you get this a lot of adipose. It starts to bleed because you're not even bleeding from major vessels. You're bleeding from all the extra vascularization into the adipose, into the lymph nodes. And then you can't see on top of that. And you're like, what am I doing? Let's just stop before I get into a situation that I can't really control anymore.
Okay, great. So next question will go to Costanza Saponaro, San Raffaele, Italy.
Hello, hi, thank you very much. I was wondering, you mentioned in a part of the article that a bedside gross evaluation of the packet might ensure that nodal tissue is present. Would you recommend incorporating this into routine clinical practice to lower ENP rates?
I think that if there's any question of whether or not this is a node versus a channel, doing bedside palpation can be very helpful. Sometimes when you have really old patients who have all of this lymph node lipomatosis, it still can be very difficult to palpate at the bedside. But at least it gives you a little bit of reassurance, and then you can say, you know, maybe I need to take a secondary node. Maybe I need to re-examine this nodal basin, ensure that I didn't, you know, just grab a channel here and grab a node. But I wouldn't say that all of our surgeons here routinely do that on every case. But our surgeons with really high SLN mapping rates, if they're unsure, they will palpate the node.
Yeah, and so yeah, I mean, most of the time it's very obvious that you got a lymph node. I mean, a lot of times there's no question. You see it, you see the pink, a nice pinkish kind of gland in your packet, right? Especially a thinner patient. But yeah, not only palpating, if you have enough experience, you usually can feel that node. If you rub it enough, the fat will kind of liquefy away, and then the lymph node won't. Another little trick I've done occasionally is you can actually cut the packet with a scalpel on the side, and then you can look at it. And I guess you have to know what you're looking at. But if you know what you're looking at and you cut the packet in half, you will notice a lymph node in there. So that's what we do. And, not only is our bilateral mapping rates different amongst us, our empty lymphatic packet rate obviously is also very different amongst the surgeons here. So, what I don't think we should do is do routine frozens of SLNs. I don't think we should ever do that. One, there's a cost to it, at least in the US. I can't speak for outside the US, but frozen sections aren't free. On top of that, they potentially ruin the node for the IHC, for the ultra staging. So at least that's what our pathologists tell us. I think others say otherwise, but.
One of the other things also at Costanza that we do is, as Mario was saying, we don't send it for frozen on tell me whether there is cancer or not, but we send it to the pathologist and just say, tell me if there is a lymph node in there.
And I was going to ask because I was curious about the macroscopic features.
Yeah, so if we have any doubt as to whether we have removed lymph nodes, we just send it to the pathologist and ask him, tell me if I have a lymph node. I don't need you to tell me.
Not a frozen. You're not asking for a frozen.
Exactly. It's not a frozen, but they just tell you, yes, there are lymph nodes there.
Okay.
And then they process it as they would otherwise. But at least they tell you right there while the patient's under anesthesia. So very good question.
Okay. As long as it doesn't incur a cost, of course.
Yes.
Palpation cost.
Next to be Ezra Delir from Germany, now in Germany.
Yes, hello, and congratulations on your paper, and thank you so much for the great presentation and discussion. And your paper mentions that the lymph node lipomatosis is a potential culprit for higher empty nodal packets rates in elderly patients. Could you please explain this phenomenon and how it tricks the surgeon intraoperatively? Thank you.
I'm not a pathologist, so I won't pretend that I can explain all of this. But upon speaking with our pathologists within our department here and reading some of the literature, gradually as someone ages, these lymph node packets are just overtaken by fatty tissue. And even like visually, I'm able to appreciate that on someone who's got like a younger patient versus an older patient. You can really see the difference in just like grossly in the lymph node there. So I certainly do think that could contribute to the decreased success and higher empty nodal packet rate. It's just more difficult to see the lymph nodes when you're dissecting, and then also, more difficult to ensure that you've got a node, not a channel.
Yeah, and heavier patients too, you get sort of these little lipomatous, they're just clunks of fat, and then you have a dilated channel going through that sort of denser, it's like a lipoma almost that people get, right? That kind of concept also. And, then you have the channels might be a little dilated, it goes through this piece of fat, it glows green, and you take that and say that's a lymph node. So I've seen that phenomenon also.
Mm-hmm. Great. Now let's talk a little bit about learning curve. Next question is from Polino Gemelli again, Alice Zampolini.
Thank you for being here. I was curious about the factors that you think could explain that discontinued improvement in sentinel lymph node mapping over time, despite all surgeons have already surpassed the learning curve before the study period.
Yeah, so learning curves are very difficult to measure appropriately, right? So, the only learning curve we really have in terms of numbers needed is an older paper from us that's saying you need 30 SLN cases to overcome the learning curve. And that was based on a bilateral mapping rate increase, which that increase was lower than what we have now. That paper was probably published 10, 12 years ago already. So, we all know that the learning curves are based on when there's a maximal change of success before and after, right? But then that success then becomes less and it gradually increases as the more you do. So it's never really truly flat in most situations for many things that we look at for learning curve. You just look at that inflection point. When you do like custom analyses and other analyses for learning curves, there's proper statistical methodology to look at where that inflection point is, where you have really a change in outcome, whatever you're measuring, based on number of cases done. Right. And you can use different metrics for success in learning curves. So, And then, but that doesn't mean that curve then becomes flat either. So if you look at our improvement, yes, it is an improvement, but like I mentioned, it's not like this, like it's 50%, then it goes up to 80%, right? And that's kind of what the early paper showed. I can't remember off the top of my head, but it was something like that. It went from a relatively small bilateral mapping detection rate to a much higher rate after 30 cases from one surgeon, by the way, who had started really SLN back here all those years ago. So we never really have looked at the learning curve. I wonder if we could do that. I mean, it'd be kind of hard now. We'd have to look at more of our junior faculty, depending on the time period, to see if we can update our learning curve, sort of how many cases needed. We have to look. The problem is also learning curves are also affected by the fact that if you train, like if you train here with us and then you stay on, you've already done 200-300 cases with us as fellows. So how does that impact learning curve, right? So there's a lot. Learning curves are very difficult. I think that you just the simple answer, I think, is that yes, there was an increase. It wasn't a tremendous increase. I just think it reflects just everyone's continued ability to do it better and better, and that's true for anything surgical.
Yeah, and I think also for the learning curve, there's continuous dynamic confounders that are impacting your outcome, right? Because then you start getting information about patient selection. You start getting information about how to inject. You get information as to newer technologies. So all of these factors are coming in at different time points in that learning curve that may potentially shorten what would have been a more traditional learning curve if everything else had remained the same. So yeah, I mean it's always a challenge as well. Nigeria, Kudus, Lawal has the next question.
Thank you very much, Sarah and Mario. So looking at the paper, the association between laparotomy and lower sentinel lymph node mapping Sussex persisted despite adjustment for BMI and age. So I'm wondering, do you believe that this reflects limitations inherent with the open approach, or are there unmeasured confounders such as case complexity, or is it both at work? And what would you recommend when open surgery is planned to improve the success of sentinel lymph node mapping?
I can get started here. I think it's certainly both. When a uterine cancer case where you think it's early stage and you're considering SLN mapping, but you have to proceed by laparotomy, at least in the United States, that is oftentimes a patient with a really big, bulky uterus, you think for other reasons. And so when the uterus is that big, sometimes it can be difficult to access the nodal basins just because you don't have enough exposure. So sometimes those cases, while we would ideally do the SLN mapping prior to doing the hysterectomy, sometimes it's just not possible. Additionally, when you're doing SLN mapping by laparotomy, you have to have your camera visualize those ICG packets, which is separate from your vision, like through your eyes. With the robot, it's overlaid, so you're able to see in real time. Whereas, like when you're doing SLN mapping by laparotomy, you have to, look at it, say, I've opened up the basins here. I think I've identified anywhere that this node could be. Then you bring your camera over, and then you look, and then you think you see the ICG, and then you try to pick up that packet. It's just it's not overlaid nicely like it is with laparoscopy. So I think that there's multiple factors at play, which certainly make it more difficult by laparotomy. I don't know if you have anything to say.
No, I agree. I mean, doing SLN via laparotomy is not fun. It's not easy. You have to have, and we're using ICG here, so you have to have the cameras for it, so it's a different camera. You can't kind of operate while you're seeing the ICG, plus you're looking at a monitor. You're not looking to find the lymph node. So usually what you have to do is you put the camera over the field. We have a handheld ICG, a near-infrared scanner, and then you look at the screen, right? Because you can't. Problem is when you're doing robot or laparoscopy, as you turn it on, you're looking at the lymph node at the same time, right? Here you have to hold the camera and then look up at a screen, and then try to do that dissect. So what we do is, because now I'm doing more of it because of this other trial, which we will not mention, that I'm doing open procedures for. And I can tell you it's very frustrating. But anyway, so you hold that scanner over, you look at the screen, and then what I do is I kind of put like a ring forcep on what is the sentinel node, then we turn it all off, and then you kind of dissect it, right? And then if you lose it somehow, you got to do it again, right? And then if you got some bleeding, guess what? You can't see it as well anymore. So there's a lot of reasons for it. Plus, it's actually harder sometimes to get down to the lymph nodes, especially if you have a deeper pelvis with sort of a very narrow pelvis. So like Sarah said, oftentimes you do an laparotomy, it's because of a bigger tumor. So you're taking the uterus out, and then you're like, then the lymph nodes are either all bloody, the area, or something like that. So I think that's why that happens. Also, age. I think age and BMI are kind of similar. Because if you have someone who's 80,
And by that, Mario, you mean age and BMI of the patient or of the surgeon?
age and BMI, and the reasons why we think it's low. So yeah, well, it could be both too, but age and BMI, I think that what I meant is the reason why it's probably low, associated with lower success rates, is because it's the same kind of concept. You have an older patient, they're not mapping easily. I'm not pushing that case, you know. I mean, an 80-year-old with a grade 1 endometrioid cancer, I mean, I doubt that, you know, she's 80, and, you know, you can't find the node easily. Am I really going to look at the para-aortics? Am I going to do a full node dissection on an 80, 85-year-old? I don't, to be honest with you, especially if it's a low grade. Or then if it's a serous or carcinosarcoma. Carcinosarcoma, everybody's getting chemo. It's like, what's the point? But, you know, so.
Mary, this next question is from also along the lines of technique, but more so about how to remove the lymph nodes. So this comes from Gabriel Levine in Israel, and he's asking, how do you remove the specimen, contained versus non-contained, and when? Do you leave it in the pelvis and remove it at the end, or do you remove it immediately?
Yeah, I mean, Sarah can I'll tell you what I do, and then she can tell you what all the other guys do here, because she's experienced all of us. And ladies, guys, I mean, yes. Okay, so I remove it right away, and yes, now we're very, very big on contained removal of lymph nodes, because that's kind of a very big thing with the service patient population. So it definitely needs to be contained. If it's small enough, we use a laparoscopic spoon. But if they put the spoon on, it has to be fully contained. If not, we'll use an endo-catch bag. I know outside of the US, we can't. I know other folks, I've seen it in other parts of the world, where they use a glove finger. They cut a sterile glove, cut one of the fingers, and put that in, and then put the specimen in there. We can't use it here because the nurses freaked out when I try to do that, because it's not radio marked, and there's a concern of retained foreign object. So we can't use that. But that's a great little technique that's inexpensive. You just kind of
clip on it.
They won't let me do it. Trust me. I tried because I thought it was a great idea. It's so much cheaper to open up an endo-catch bag, you know. So, but that I do use a bag a lot more often now. Yes, and I take it out right away. I don't leave it in the abdomen, unless you have it in a bag. If you don't leave it in the abdomen, I wouldn't just leave it there, because you run the risk of it getting lopped off and going up into the upper abdomen, then you can't find it. I mean, there have been cases where even a uterus has been lost in the upper abdomen, and they'd had to open them to find it. So I think it's best to take it out right away. Yes, contained, because it's cancer. You don't want to chop up a cancer-filled node through a trocar site. That's not good cancer stuff. And that's what I do. What are your impressions?
Yeah, essentially everyone removes it contained either within the spoon or the endo-catch bag, and removes it at like right after dissecting out the node. So I think like the only times I've ever seen someone like not immediately remove the specimen within a bag is like if you have just a 5mm assist port, you don't map on one side, and you do have to do a site-specific lymphadenectomy, then you have a little bit more nodal tissue, and then, you know, it's within the bag. You'd remove the bag after you take out the uterus.
Yeah, so that's a good point. Even if you just do a sentinel node, especially the heavier patients, sometimes those nodes can be pretty bulky. So if you have a 5mm trocar as your assistant, you're not going to be able to take it out. Then you have to leave it in somehow in a bag or something and take it out later through the vagina. Sure. But I use 12mm trocar all the time for endometrial cancer staging, just because you pass needles through it. I think everyone's big on trying to do less trocar, smaller trocars. None of that's going to make patient outcome any different. And I don't like to struggle. So if you use a small, even an 8mm trocar, when I use that, like the air seal, sometimes a bigger SLN with some fatty can't come out through that. And if that ever happens, even with a 12 sometimes, then we'll leave it in the bag inside. I mean, if it's in a spoon, it's going to come out, right? If it doesn't, and you put it in a bag and it doesn't come out the trocar, then we'll just tag the string outside and leave the bag inside and then pull it out vaginally after the hiss is done.
Great. Next question is from Christina Kohler in Heidelberg University, Germany.
Thank you. So coming back to the topic of obesity, the manuscript reports minimal invasive surgery as a single group, so including both conventional laparoscopy and robotic-assisted surgery. I'm wondering, given the potential technical advantages of robotic surgery in patients with severe obesity, was any comparison performed to evaluate whether the surgical platform influenced bilateral sentinel lymph node mapping or empty nodal packet rates, particularly across BMI categories? Thank you.
Yeah, I mean, that's a great question. We did look at, so we do have that information, but considering that primarily only one surgeon here does laparoscopy, it's more of a reflection of one surgeon's outcome versus the rest of the group. So we aren't sharing that information. But we do have that information. Off the top of my head, in terms of BMI groups and between the two, I don't have that. I do have like rates of conversion to open and things like that. And then in the BMI over 60, they were all robot cases. So we don't even have the opportunity to compare. So again, our view here has been that it's all laparoscopy and that whatever tool you have at hand to do laparoscopy is more important than, comparing robot to non-robot MIS. That's kind of always been our message here. So we do have that info. We're not really sharing it.
Christina, the other thing also is that in evaluating the literature, it may seem that robotics is at a much higher advantage in terms of the performance in the detection, but also remembering that this is a comparison of laparoscopy versus robotics is likely to be sequential, not concurrent. So you have laparoscopy being hurt by this is the initial learning curve of those surgeons. You didn't really know how to select those patients very well. You were doing it with blue, you were doing it with technetium, you were doing it with green, and then here comes robot. You're past your learning curve. You're only doing it with green. You're selecting patients. So you have like detection rate of like 40% in laparoscopy, 90% in robot. And then you might say, well, of course it's the robot that's better. You got to take all of that into consideration as well.
Yeah, you would ideally, you obviously do a randomized trial, but no one has an interest in doing a randomized trial for something like this because no one's got money for it, and there's more important things to ask. But the really way to do is if you somehow had a large data set where you have concurrent experienced surgeons in laparoscopy and robotics to then compare that. So you have to have a larger data set with folks who just primarily do laparoscopy and no robot, and folks who just do robot now. With experience, and then compare, see if there's any differences there.
And same dye.
And using the same techniques and all that stuff too. Of course, you have to use ICG, and so in a retrospective way, you could do that again. That's a question that, to be honest with you, I'm not as interested any longer in. Robot versus non-robot stuff. As long as you're doing laparoscopy, I know there's some impetus for some places to try to, with the way they access robots, to try to provide more value to robot with data like this. We're not going to be the ones to help there.
Okay. So as a last question, we go to Camila David from Budapest, but who is now here at Houston Methodist.
Thank you, and congratulations for the paper. So the study mentions that most operative notes lacked a state hypothesis for why mapping failed. What do you think? What specific intraoperative details should surgeons document when a map fails?
I mean, as the fellow going through all of these op notes, and also as the fellow, doing some of these cases, sometimes it just doesn't map and you don't quite know why. I did note in some of the op notes that they would say, we encountered all of this retroperitoneal fibrosis, either due to, a prior history of radiation or prior surgery. But, it certainly wasn't consistent. So I think if you notice something during surgery, it's like important to write it down in an op note so that maybe someone would use that later. But consistently, I wasn't able to discern anything. Yeah.
I mean, from a personal perspective, every time I mean, the times when they don't map is usually the heavier patients, as you know, or there's like this weird retroperitoneal edema and fibrosis, maybe from old endometriosis. And there's a few cases who've had radiation for like rectal cancer, then developed endometrial cancer. And in those situations, I personally make an effort. I put it in my note if there's obvious reasons for no mapping. But for someone who's obese and it just didn't map, I'll put in there now, do the adiposity in the retroperitoneal. I've started to at least do the significant adiposity in the retroperitoneal space. So it was difficult to do a safe SLN mapping this dissection. I've started to do that now. I think as much information you can in op notes is great. It also helps patients understand, maybe why, because now that everyone's getting their notes, it also maybe helps them understand why you didn't map or why you didn't do something. But, they just read adiposity retro, they're like, oh, he's calling me fat, right? So it's a little bit of a challenge now with patients, at least in the US, getting access to every single note that we ever create. You have to be a little careful what you put in a note too, right? And but yeah, and then it's of course helpful when you do the retrospective reviews of notes to have as much detail on there as you can. But from a clinical standpoint, does it really matter why they didn't map? No, probably not, I guess.
So Mary, it's the last question, and we're coming to the end of the Journal Club, but just from a technical perspective, you're in a training program. Who injects the cervix for endometrial cancer patients? Is it the fellow or is it the attending?
It's a mix.
As a fellow, it's a mix. Some attendings are very particular about their ICG injection, and their perspective is, this can make or break my surgery. Like if the injection's not right, if the manipulator isn't placed, correctly, then this whole case is going to be a struggle. And then other attendings let the fellows place it. So it just depends. I would say more than 50% of the attendings let us do the injection and place the manipulator.
It'd be interesting to see if there's a difference between that, but we don't designate that in an op report, obviously, who did the injection. So we'll never have that info. But yeah, for me, it depends on the fellow also. I mean, a lot of times they're just setting up and I just go between the legs and just do it all. It's not like I mandate that I have to do it every time. Obviously, when the fellows are first coming around, I like to show them my way, right? And I do that. And then I've had some fellows do it routinely and others, they're just setting up and I just go down and put them, inject and put the manipulator in. So I personally don't have there are some faculty here who really feel strongly the way she says, and others are kind of, well, let me show and then let me see how they do. And then I do it together the first few times. Then if I feel that they're doing it the way I do it, then I let them do it going forward. So.
Yeah. All right. Well, Sarah, Mario, thank you very, very much. As always, it's a great opportunity to learn from both of you, and we really appreciate you taking the time and accepting our invitation. Thank you for submitting the article to our journal. I want to thank all the fellows for putting together their questions as well, and everyone who participated and submitted your questions. Definitely want to invite everyone to the August Journal Club. It'll be on an article titled PARP inhibitor maintenance therapy with niraparib in patients with primary, advanced, or recurrent endometrial cancer receiving dostarlimab plus chemotherapy with Dr. Matt Powell. So again, thank you all for joining. Thanks for this time and this opportunity, and look forward to seeing you again.
Bye, everybody.
Thank you.